Good afternoon, everyone. I'm Dr. SAUMYA G, Senior Lecturer, Department of Conservative Dentistry and Endodontics, Annoor Dental College. My seminar is on the topic cleaning and shaping. So, starting with the introduction, endodontic treatment mainly consists of three steps, that is, cleaning and shaping of root canal system, disinfection, and obturation. So, what is cleaning and what is shaping? Cleaning refers to it comprises the removal of all potential pathogenic contents from the root canal system, whereas shaping it is the establishment of a specifically shaped cavity which performs the dual role of three-dimensional access into the canal and creating an apical preparation which will permit the final obturation instruments to fit easily into the canal. So there are three objectives which is given by Schilder, that is mechanical objective, biological objective, and clinical objectives. The mechanical objectives are the root canal preparations should develop a continuous tapering cone. And next is making the preparation in multiple plane, which introduces the concept of flow. Then making the canal narrow apically and widest coronally. Fourth is avoid transportation of the foramen. And fifth, keep the apical opening as small as possible. Then the biological objectives, there are procedures should be confined, it should be within the confines of the root canal space. It should not be extended beyond the foramen. All infected pulp tissue, bacteria, and their byproducts should be removed from the root canal space. And the necrotic debris should not be forced periapically. If you force the debris or any irrigants or anything beyond the canal, it can lead to further pain and swelling, etc. And then sufficient space for intracanal medicaments and irrigants should be created so that a thorough cleaning of the cavity is possible. Next is clinical objectives. It includes removal of the overlying dentine, causes smooth internal walls, and provides straight line access to the root canal. So initially we need a straight line access into the cavity. So hence the overlying dentine have to be removed. After obturation, there should be complete sealing of the pulp chamber and the access cavity so as to prevent any kind of micro leakage. Tooth should be restored with permanent restoration to maintain its form and function and also aesthetics, and patient should be recalled on a regular basis for evaluation. The removal of overlying dentine causes smooth internal walls and provides a straight line access which can be seen in the diagram below. If we don't have a straight line access, it can lead to various complications like incomplete cleaning of the canal, and also in some cases there can be fracture of files, and in some cases the rotary files will find it difficult to reach to the periapical region. Next, instruments used for radicular preparation. There are hand instruments which includes broaches and file, then rotary instruments like gate grid and drill, protaper, profile, grated raper, Quantic file series, light speed, K3 file, and Hero 642. Then there are automated instruments like sonic and ultrasonic devices. Then lasers can also be used in cleaning and shaping. Then there are different movements of the instruments using which the canal can be cleaned and shaped. This mainly help in the enlargement or widening of the canal. So that is push and pull, reaming, turn and pull, watch winding, and balance force technique. Reaming motion, it is a repeated clockwise rotation of the instrument which will shape the canal walls and give a cross-sectional preparation approximately which is round. And reamers are mainly used for this reaming motion. Coming to filing, it is a push-pull action without rotation, which has a great efficacy with files than reamers. The cross-sectional appearance of the prepared root canal is irregular with a general oval configuration. Next is combination of reaming and filing. In this technique, file is inserted with a quarter turn which is given clockwise and then apically directed with pressure and then subsequently withdrawn. And balance force technique, there is insertion which will be done in clockwise 60 degree Then apical push with a rotation of 120-degree counterclockwise is given, and then the removal of the given 60 for the removal of the file, a 60-degree rotation which is given clockwise. Next, watch winding motion. In this, the arch arrow which is given on the diagram indicates a gentle right and left motion with causing the instruments to cut, while a light inward pressure which keeps the file engaged and progressing towards the apex. And in this, the rotation motion which we give for watch winding is 30-degree watch winding motions. It should be clockwise as well as anti-clockwise within the confines of 30-degree. Next is watch winding and pull motion. This is usually used primarily for with a headstone file, that is a H file. In this, inward pressure is maintained while the file is gently rocked and right and left through the arc indicated by the shade region of the circle, which is shown in the diagram. And when insertion stops, all rotation is ceased and the instrument is then withdrawn. Now coming to the motions of the instruments for cleaning and shaping. There are mainly 6 unique motions of the file that will be files and reamers, both which will be used. They are follow, follow withdraw, cart, carve, smooth, and patency. So what is follow? It is in this the file is pre-carved and follow the canal curvatures, because the file which if it is straight and if we put in the curved canal, it can lead to any ledging or perforations, etc. Hence it should be pre-carved. Next, follow withdraw. In and out motion is given to the instrument. It is done to create a path for foramen. And cart is carting actually means transporting. So it refers to the extension of a reamer to or near the radiographic terminus. The precurved reamer should gently and randomly touch the dentinal walls at the radiographic construction and cart away the dentinal debris and pulp remnant which is present. Then carving is for shaping of the canal. The key is not to press the instrument apically, but simply snugly move into the dentine with a pre-carved reamer and shape on withdrawal. And smoothing is circumferential filing and is usually accomplished with files. So it is not necessary that the canals are in round shape, or it can be ribbon shape, oval shape, etc. So in this, a circumferential filing is done, which gives a smoothing of the canals. Sorry. Patency, it is achieved with files or reamers. It means simply the portal of exit has been cleared of any debris in its path. So during cleaning and shaping, or after each exchange or increase in the file, so in that during that time, we have to check for the patency in order to prevent any clogging of debris at the apical region. Hence, the patency should be checked using a smaller file to see the portal of exit and clear the debris which is clogging the canal. Coming to the basic principles of canal instrumentation, there should be a straight line access to the root canal system. As I said earlier, there should not be any dentinal obstruction which should be present. The file should be easily moving in a straight line with a straight line access into the canal. Then copious irrigation should be done in between the instrumentation in order to remove the loosened debris from the canal. And prepared canal should retain its original form and shape. The canal should not be over prepared, like scraping of dentin. More of scraping should not be done, or perforation or stripping, etc. should be avoided. Like it should not happen. Then exploration of orifice should be done with a smaller file to gauge the canal size and configuration. We should not insert a larger size file directly, so that we have to gauge the size of the canal, because it is not clear from a radiograph whether it's oval or like ribbon shape or anything. So hence it should be a canal filed very with a smaller file size. Canal enlargement should be done using instrument in a sequential order. Never ever skip files and go with a larger size file to save time. Okay. Flutes should be cleaned and inspected after each removal. So there can be debris which will be accumulated in the file flutes. So that have to be cleaned after each time you introduce it into the canal. Never force the instrument in the canal. Recapsulation is regularly done to loosen the debris. Recapsulation means you are using, suppose you are using a 15 number file and then you finish cleaning, then you're going to a 20 size file. You did 20 size cleaning, okay, after irrigation. So there can be debris or something present in the canal which will clog the canal. So hence after 20, you come back to the smaller size, that is 10. You started with 10, then you have to introduce 10 to see the patency of the canal, in order to prevent any debris clogging into the canal. Then over preparation and too aggressive over enlargement of the canal, curved canal should be avoided. In case of curved canal, there can be chances for more of stripping, etc. So hence over preparation should be avoided. Overusing of large file must be avoided as it may result in further enlargement of the apical opening. So apical, initially in the mechanical principle, as we mentioned, the apical opening should be very small and the coronal opening can be enlarged. Now, coming to the techniques of root canal preparation, there are mainly two techniques. One is apical towards the coronal technique, and the other one is coronal to apical technique. So the various techniques, they have further like modifications have happened. So in apical to coronal preparation, there is standardized technique of canal preparation, then step back preparation, modified step back preparation, and passive step back technique. And in the coronal to apical direction, there is step down, crown down pressureless technique, hybrid technique of the canal preparation, balance force technique, reverse balance force preparation, double flaring technique, modified double flare technique. Coming to standardized preparation technique, it was introduced by Engel. In this procedure, the working after the axis opening, the initial determination of the working length is done initially, and the X-ray etc. is taken, and then select a initial apical file which can be used. Then circumferential filing to increase uh, apical construction, that is 2 to 3 file size larger to that size, and we have to prepare the apical preparation, which will be the initial apical file. Suppose you are using a 15 file, you are getting a tightness in the canal while taking a working length. What you have to do is you have to increase that size till the apical opening, foramen, sorry, minimal construction, till the construction using the next size or 2 to 3 file we have to increase, and then that will be the apical preparation is only done, okay, with the same length. That is called as standardized preparation. This increase incidence of ledge zipping and perforation, because we are introducing larger size file and it is going straight down, right? So because there is no enlargement on the coronal portion, hence there are chances for zipping, ledging, etc. and perforation. So coming to diagrammatic representation, in this there is same procedure. As I said, we have to take a working length. Then a small size reamer is introduced into the full length of the canal, and then 2 to 3 file size increase will be used, or successive larger files are used entire length to prepare the apical preparation. Next is step back technique. It is also known as telescopic canal preparation, serial root canal preparation, etc. It emphasizes on keeping apical preparation small in original position and introduce a gradual taper coronally. Okay. In the other standardized technique, we are only enlarging with the same length and we are not giving any kind of taper. In this one, there will be taper which is given to the canal, which is the original shape of the canal. And the preparation is mainly done in two phases. There is phase 1 preparation and phase 2. In phase 1, you're doing the preparation of apical construction, whereas in phase 2, you'll be doing the preparation of the remaining canal. So the phase 1, in this you evaluate the tooth decay causing pulp exposure, that is the diagnosis part, etc. And after that, once the tooth, if it is involving pulp, the patient is advised for RCT. In such cases, you will be administering local anesthesia, then application of the rubber dam, etc. Then prepare the access cavity and locate the canal orifice. Then later we go for the working length determination, and then insert first instrument with watch finding motion with gentle clockwise and anti-clockwise motion to the file and then remove the instrument and irrigate the canal. After each filing, you have to recapsulate and irrigate the canal. So recapsulation using a smaller size file to break and the apical debris and repeat the process until a size 25K file reaches the working length. So suppose you introduced a 15 number file. Next, you are increasing to 20, then 25. A 2-3 size file increase or successive files are used in this procedure. This is this phase 1 in which only the apical preparation is done. So coming to phase 2 in this, place next file which is 1 mm short of the working length. Okay. So phase 1 in which you are doing only the apical preparation. Coming to phase 2, next you are reducing the length of the file. Suppose your file is going till 20 mm. In next file you are taking as 20, after 25 is 30, right? So 30 number file, in that you are going to measure the working length as 90, 19, 19. Okay, and then do a watch winding motion, circumferential filing, irrigation, and recapitulation. Then repeat above steps with larger files at 1 mm increments from previously used file. So after that, you're going to reduce more of 1 mm file. When you are increasing the file size, you're reducing the working length. And then refine root canal by master apical file. After the enlargement or flaring is done, you are using a master apical file. Suppose that is 25, you will be putting it into full working length and then giving us or smoothing the canal, which will be run circumferentially in order to get a continuous taper. So diagrammatic representation, as I said, in the first phase, you are doing the apical enlargement. That is a initial apical file you used is 25 file. Okay, so that is red, and next is 30, which is blue file. So this one you are reducing 1 mm or you are keeping it 1 mm short of the working length. And next file after irrigation and recapitulation, you'll be using 35 number file, which will be 2 mm short of the working length. Next, you will be using 40 number file after irrigation and recapitulation. Unconditionally, okay? Unconditionally, after each filing, you will be using the next file. When you're using the next file, you have to irrigate and recapitulate. So in 40 number file, you'll be reducing 3 mm. In this, so 1 mm, 2 mm, 3 mm. Okay. As you increase the file size, you'll be reducing 1 mm each. And then in 45 number file, you'll be reducing 4 mm short of the working length, and 50 file for the canal for canal preparation you'll do. In this, can you see in the diagram, you're getting a step, right? You're not getting it a continuous flare, like a flare is not continuous. Hence, what you do is after that stage, you insert a 25 file, which was the master apical file, and then you pull it up or scrape it in such a way so that the steps becomes continuous, and you have to do it circumferentially in order to get a smooth finish to the canal. Now, there are variations in step back technique in which the enlargement of the coronal portion of the canal is done using a Gates Glidden drill, a larger size, and a use of small to prepare the mid-root region. Now, coming to the advantages, there are more flare at the coronal part of the root canal with periapical stop. So, proper apical stop, sorry. And the disadvantage of this technique is the variation, okay? In that technique, the disadvantage it is difficult to irrigate apical region and chances of pushing debris apically. It is time consuming, and iatrogenic errors like ledge formation in curved canals may occur. It is difficult to penetrate instruments into the canal, and more chances of instrument fracture can occur. Coming to modified step back technique, in this, the preparation is completed in apical third of the canal as in the first phase, okay? So in the second phase, it's not divided into phase 1, phase 2, but the procedure is the same till the first phase. Then step back procedure starts by, like in phase 2, what we did is we reduced 1 mm each, right? Instead, in this technique, you'll be directly reducing 2 or 3 mm, which will be reduced short of the working length. And this gives a parallel portion, which increases the retention from apical area. This receives the primary Muvattupuzha points, which show slight tuck back when the point is removed, and hence it has more retention. Coming to passive step back technique, it was introduced by Torbinizet in the year 1994. It is a combination of rotary and hand instrument for the root canal preparation. There is passive enlargement of the root canal, which is in the direction apical to coronal. That is the initial technique. So that is the advantages is provide significantly cleaner canals, less chance of transportation, and ease of clinical application and applicable in every canal types. Coming to crown down technique, in this the dentist prepares the canal from the crown to the tooth. So in the step back technique, what we did is from the apical portion, we went to the coronal portion. Okay. So in crown down technique, what we do was we enlarge the coronal portion initially, then smaller size files are used to clean the apical portion. Morgan and Montgomery found that this crown down pressureless technique resulted in rounder canals shape when compared to the step back technique, because initially we are using a smaller size in the step back, so we don't know the canal shapes, and we are going to get a irregular or a we are not going to get a symmetric canal shape. Okay, in this you're using a larger files, so you're going to get almost a better symmetrical canals. Early coronal flaring with Gates Glidenberg can be done, and incremental removal of dentine from coronal to the apical direction is done. A straight K-type files are used in large to small sequence with a reaming motion and no apical pressure is given. So in step back, we have used a smaller file to the larger file, whereas in this crown down technique, we are using a larger size file to a smaller size file to give a flare of to the canal, and we are not applying any kind of force or pressure. Coming to the steps, there's a straight line access to the root canal system which have to be achieved. An access cavity is filled with irrigant in order to have a lubrication of the canal. Then flaring of the coronal third of the canal using GG drills. The coronal portion you can initially start with a larger, then to the middle portion you can go for the smaller size GG drills. Then excessive use of GG drill at same level leads to excessive cutting of dentine and weakening of the root, and thereby giving a cork bottle appearance in the radiograph, as you can see in the diagram. So then establish working length with small instrument after irrigation and recapitulation. Then use of a large file. In the other one we have start with 10 number files, etc. Right? In this you're going to use a large size file or a large size, yeah, to the in the coronal third, and you're not applying any kind of pressure. Then in second one, the preparation of the canal at the middle third with subsequent smaller size. So you know the coronal portion is little wider, whereas as it comes down or descend down towards the apical portion, it's little narrow. Hence you have to reduce the size of the file. Then apical preparation of the canal with frequent irrigation of the canal system. Then this is the image of a well prepared tapered preparation of the tooth, which will be achieved after a thorough cleaning and shaping. Coming to balance force technique, in this the positioning and preloading an instrument through a clockwise rotation and then shaping the canal with a counterclockwise rotation, as we studied in the motions of the uh, files initially. Balance force technique, you use initially a clockwise rotation, then an anti-clockwise rotation, and remove the files. Okay, so there is phase 1, phase 2, and phase 3. The phase 1, there is placement phase in which you place the file. Then phase 2, cutting phase, you are rotating the file in a clockwise direction. Then you turn it 120 degree, it goes down, right? And then you're turning again clockwise and removing it out. So that phase 1 is placement phase, phase 2 is cutting phase, and phase 3 is removal phase. So coming to balance force technique, this is the like diagrammatically, you have to engage. This is the engaging, that is dentine with a light quarter clockwise turn, which is given at 60 degree. As I said early, you have to place the file with a light 60-degree clockwise rotation. Then in the cutting stroke, turn the file counterclockwise and pushing apically. When you turn it counterclockwise, automatically the file goes down. Okay, and then in the clearing phase, you have the cutting debris which you have collected after going down. You have to rotate it clockwise again 60 degree and then withdraw it. That is a clearing phase. The advantage of this technique is this technique balance and maintains the file's central even in a curved canal. So you have a control on the instrument. It is maintained in the center, and it has better control of file, allows selective cutting. It avoids transportation, and there are disadvantages normally. With every procedure, there can be advantages as well as disadvantages. Okay, the disadvantage in balance forces, a wide preparation, which may lead to perforation. Instrument is prone to fracture, and improved tactile sense required to control this instrument. Coming to step down technique, in this the preparation of coronal third is done in two phase. Step down, okay, that was step back which we discussed initially. In this there is phase 1 in which root canal is penetrated with a Headstone file, that is H file, and phase 2, GG drills are used to flare the coronal segment of the root canal. The advantages are it has straighter access, it eliminates the coronal interferences, it removes the bulk of the tissue and microorganism before the apical shaping. So in this, you're not pushing the debris down. You're whatever debris is there on the coronal portion, you're removing and cleaning and then going downwards. And working length retention is there, and better and deeper penetration of the irrigant. As you're cleaning the canal, there is more space for the irrigant to flow in. There is better cleaning in. Coming to hybrid technique, it's a combination of step back and crown down technique. It uses both rotary and hand instrument. Hand instruments secure a patent glide path. Tapered rotary instruments efficiently enlarge the coronal portion of the canal areas. Coming to double flare technique, it's a canal is explored using a small file. Then canal is prepared in crown down manner using K file in decreasing size. The step back technique is followed in 1 mm increments with increased file size. Both both the technique, it's double flaring is given. Okay, the indication is it is done in case of straight canal, then straight portion of curved canal. Curved canal is not curved from initial, right? There will be till a portion, it will be straight. After that, it goes for curvature. So till the straight portion, you can use a double flare technique. Then coming for contraindication, that is in case of calcified canals, it's not possible, and young permanent teeth with open apices. Now the engine driven or rotary instruments, as we said earlier, there can be hand instrument, rotary, then sonic, ultrasonic lasers, etc. Coming to the rotary, in this there are various file systems like night-eye rotary instruments which will be used. They are Pro Taper, Profile, Greater Taper, Quantec 2000, Rays, which is rotary with alternating cutting and alternating, edge, K3, Hero 642, and Light Speed. These are the instruments that is used. Coming to ultrasonic instruments, it was suggested by Richman. The movement of the file shaft between 0.001 to 0.004 inch to 2000 at 20,000 to 25,000 frequencies per second. For free movement of the file in the canal, it should not have any binding, specifically at the apical end. It should not have any obstruction for the free movement of the tip within the canal. For the technique, the 10 and 15 number files are recommended. That is a hand files. Then file inserted to full working length, and the movement circumferential motion is given with smooth push and pull stroke. Time duration at least 1 minute. It should be placed within the canal, and copious irrigation using sodium hypochlorite irrigation must be done. Coming to the mechanism of action, in case of ultrasonic cavitation and implosion, there's growth of bubbles which will be in negative pressure, which will be there, and this bubbles maximize in size, and then it collapses or implosion of this bubbles takes place. Later, again small bubbles are formed, and these bubbles are enlarged or maximized, and again further explosion takes place. So this cycle repeats and new bubble growth starts. So this is the mechanism, and this is how the debris are loosened within the canal using an ultrasonic instrument. The advantage is it has better cleaning, enhanced chemical and antibacterial action of irrigants, and the disadvantage is apical third of the canal need to be hand instrumented. We cannot directly use an ultrasonic instrument. So now coming to the conclusion, the combining the art of proper cleaning, shaping and science of immaculate cleaning with culminate in ideal biomechanical preparation. that will lay the foundation for ideal obturation and healing and ultimately successful endodontic therapy. Thank you.